One more minute. Perfect. Once it hits 7:01, I'm going to give it the go. There's Jonathan.
As our guests settle in, I would like to make everybody aware that we have pretty relevant, important, and incredibly timely forum luncheon a week from next Monday, which will kick off our series. Thank you to PG for sponsoring that event. We will have Oregon Director of Education, Colt Gill. We are bringing the top to all of you. Much like having Director Wood on here today and our great leader of Salem Health and Cheryl Nestor Wolf, we are bringing the top talent direct to our membership. And the timeliness, of course, of having Director Gill is pretty crucial as we head off into a school year and just a matter of days across the state. And so we would invite you to join us on Monday, September 13th, 11:45 a.m. at the Salem Conference Center. We are going to be in person, at least for our kickoff forum luncheon. And we'll see, obviously, the state of affairs within the state. If we will be having future forum luncheons in person, we certainly hope we will. But we'd invite you to be at that program. It'll be really a great time for all of our membership to connect directly with Director Gill and have some dialogue back and forth, but certainly understand the state's game plan for rolling out education for the next 9 months. Zachary, I think we're ready to roll. I'm going to turn it over to you and Director Miller.
Thank you, everyone, for joining us on this early Thursday morning. Super excited to bring you guys some really relevant information in regards to the most recent mask mandates. And we've got a great slate of speakers that are going to talk on a number of topics that relate all to masks and talking about what Salem Health is looking like, things you need to know from a attorney's perspective for potential vaccine mandates and mask mandates. So thank you all for being here. And Jeff, I will turn the mic over to you.
Morning, everyone. I can't believe it's September already. I don't know about you. I love summer. And don't get me wrong, I love some fall colors and all the things that come with it, but I hate the winter. So it's always good and bad for me on this September. So welcome to September 2nd. Like Zachary had said, we have a good slate of speakers this morning. And I think before we do that, we need to get into some self-introductions. Tom or Zachary or one of you running with that?
Director Miller, I think we're, for the sake of time, since we have 4 speakers, we're gonna skip that portion for this meeting.
Okay. That said, when we skip these types of self-introductions, everyone is involved in the chat. I would encourage you to put your contact information in the chat. So if someone needs to get a hold of you or has a question for you, they can reach you that way. In addition, as there's questions that come up throughout the day or throughout this morning's conversation, if you had a question and you want to direct it to a specific speaker, that would be ideal. And then the panelists will also be monitoring that as we go along, hopefully, so that they can jump in and answer those questions as they arise. That said, I'm going to do a quick little bio of our speakers today. Bear with me as I get ready. All right. Marion County Commissioner Colin Willis is with us today. Thank you, Colin. Colin Willis was elected to the Board of Commissioners in November of 2018. Commissioner Willis serves in the community on the Executive Council for Strategic Economic Development Corporation in the Mid-Willamette Valley, which is also known as SEDCOR. Mid-Valley Homeless Initiative, Willamette Health Council on the Finance Committee, and leads the Marion County Housing Initiative. Commissioner Willis's policy interests include economic development, housing, homelessness, healthcare, transportation, waste management, land use, and public safety. Prior to being elected to Marion County Board of Commissioners, Cullum served as an aide to the U.S. Senate Joint Economic Committee and represented small businesses, entrepreneurs, and nonprofits as a business attorney. Thank you and welcome. Director of OSHA is with us today, Michael Wood. Thank you, Michael, for joining us. Michael Wood became the administrator of the Occupational Safety and Health Administration, other known as OSHA, of the Oregon Department of Consumer Services in September of 2005. Prior to taking that responsibility, he was employed by the state of Washington for more than 21 years. After 3 years working in the Washington State Legislature, Wood worked for the Washington Department of Labor and Industry in a variety of capacities, including more than 10 years as the Senior Project Manager for Washington Industry Safety and Health Act, also known as WISHA. As Policy Technical Services, and 8 months as the Acting Assistant Director for WISHA Services. It's a mouthful, and I apologize. He also spent 4 months administering the Washington Self-Insurance Program. Michael is a certified safety professional and graduate of Gonzaga University in Spokane, Washington. Thank you. Randy Sutton from Saffield Griggs is here also today. Randy, thank you. Randy is an experienced litigator who focuses his practice on business and employment litigation matters. Randy also advises employers regarding employment law compliance. With over 20 years of law practice, Randy is highly regarded as a skillful litigator and frequently speaks on employment law compliance issues. Randy advises management with different employee relation issues and helps employers stay compliant with state and federal employment law. Randy advises employers regarding effective employment policies and prepares employment and non-competition agreements. Last but not least, certainly, is Cheryl Nestor Wolf from Salem Health. Thank you for joining us this morning as well. Cheryl Nestor Wolf came to Salem Health Hospital and Clinics, also known as Salem Health, in 2007 as a Senior VP of Operations and Chief Nursing Officer. Salem Health includes Salem Hospital, West Valley Hospital, the Salem Health Medical Group. Cheryl became Chief Operating Officer in 2010, taking charge of the day-to-day operations of the two-county hospital system that currently employs approximately 5,000 staff members. Since being named as President and CEO of Salem Health in November of 2015, Salem Health has expanded from 454 to 494 beds. And for the people out there that aren't great at math, I think that's about 40 beds. Quick math in my head there. Salem Health Medical Group has significantly expanded. Salem Health began partnering with providers in the county on 2 ambulatory surgical centers, which are now in progress. And a major campus expansion is underway, as I'm sure everyone knows. They've seen that. I don't know how you could not have seen that. Prior to her arrival, Cheryl was Vice President and Chief Nursing Officer at O'Connor Hospital in San Jose, California, and Chief Nurse Executive and VP of Nursing and Patient Care at St. Mary's Medical Center in San Francisco. Cheryl has served on numerous boards, including the United Way of the Mid-Willamette Valley, the Northwest Organization of Nurses Executives, Nurses Week Advisory Board, Willamette Valley Community Health, and the Salem Chamber of Commerce. She recently served as director of the board of Oregon Association of Hospitals and Healthcare Services. I'm gonna mess this up, but it's OAHHS. She currently serves on the OAHHS policy board as a board member of the Salem Boys and Girls Club and regional director of the Portland branch of the Federal Reserve Board. So Cheryl, it sounds like you are awfully busy along with everybody else. So with that, I just want to jump in and say, first and foremost, thank you for the four of you, and as well as the others that have jumped on this call this morning. It's always good to see so many faces. And I think what I'd like to do is, we've got some questions here for each panelist, but I think I just want to start off first by asking Colum. There was a recent passage of 21R20, and I was hoping you could just go into that a little bit, Colum, and talk about the decision that went into that and how that could affect things in Marion County specifically.
Sure. Thanks, Jeff. I think the resolution basically said, asked the governor, stated that we want local control of our response to this pandemic, and that was what she promised. And as a result, we're not going to use our county resources enforcing statewide mandates. And I think the philosophy behind this is, after whatever, I'm almost 3 years in the county, I realized that the state basically is regulatory in nature primarily, and county governments are primarily service oriented in nature. So we provide a lot of direct service, and the state really doesn't provide a lot of direct service. And it creates sort of different understandings of the world, I would say. And especially for the state, they tend to regulate entities primarily, and most entities, especially businesses, nonprofits, they want to make a profit, and so they can adjust to whatever regulatory scheme the state basically comes up with, or they go out of business, right? But when it comes to regulating individuals, the state doesn't have as much experience with that. I would say the counties have way more experience when it comes to dealing with providing direct services to individuals, and trying to implement regulations with individuals. And what we've learned is that trust is really, really, really important. Building trust is really important. Maintaining trust is really important. And when you lose that trust, it kind of doesn't matter what piece of paper you put out there, or what law you say you make, or what regulations you put out. If people reject those out of hand and they don't want to comply with them and they want to dig their heels in, it can be really hard to actually get the policy outcomes that you want to see in the world, because there's just a lack of trust. And I think right now we're in a situation where there's a real lack of trust in government generally at all levels, and specifically with our state government. And so what we said, and what we continue to say, is local control of this is better. The more local, the better, because the closer you are to the people that you're regulating and serving, the more you understand their circumstances, and the easier it is to build trust in the community and get the whole community moving together in one direction. And I'll give you just a couple of examples of this, because sometimes people will say, oh, well, the counties weren't doing anything, so the government had to take over. And that's just not true. And I would say where the counties really have played the largest role in this pandemic have been where there's been limited resources of things. So both with PPE early on and then with vaccines early on, the counties were really the ones that were directing resources, scarce resources, to different providers in the community. And one of the things that we saw early on was that in North County, we had pretty high case rates. And we also, our Latino population was hit disproportionately with this disease. And what we did early on was we really invested in relationships with some of the nonprofits in North County and nonprofits that work with Latino families in our community, and with Woodburn Ambulance, and started really doing testing events and building relationships and educating about the disease. And then when it came time to allocate vaccine, we allocated a lot of early vaccine up to Woodburn, and we had weekly vaccination clinics with trusted partners. So it wasn't just Marion County going up there. It was people that folks had worked with, they knew, they had longstanding relationships with. And as a result, Marion County, we're tied for the highest vaccination rate among the Latino population of any county in the state. We have a higher vaccination rate among our Latino population than Multnomah County does. So I think that's just one example where the county really took a leadership role in building relationships, and it had a real positive policy outcome that we're seeing now. The second one was early on in the pandemic, we had to allocate PPE. And one of the things that we did was we went to our dentists, frankly, and we said, hey, we need to steal your PPE from you. And this was a time where everybody was hiding their PPE. because you couldn't get masks, right? You couldn't get gloves. Everything was tight. And so when PPE became more available and OHA was giving us bigger allocations, we said, okay, we're going to give some of this back to the dentists, because we took some of their inventory and gave it to our hospitals and EMS providers. And OHA said no. They said you can't do that. But from our perspective, that was a promise we made to them that we would make them whole. And if we don't keep that promise, then we've just broken trust. And then you got a very serious problem on your hand when you have a crisis in the future and you actually need some help. Those people aren't going to show up to help anymore, right? They're going to hide that. And so we made the decision, no, we're going to do that anyway. We're going to do that even though OHA doesn't want us to do that. And then I would say the third example that I want to talk about is early on in the pandemic, we also started noticing that we were seeing much higher death rates from our nursing homes than we wanted to see, and higher case rates, frankly, from nursing homes that were saying that they were complying with the distancing rules and everything. And we're not the regulatory body for nursing homes, DHS is. And so, but we started kind of hounding DHS, like, what's going on here? What's going on here? And what we found out was DHS wasn't doing site visits because of COVID. They were doing it via screen. So, somebody from the nursing home would have like an iPad and kind of walk around the place, and they would use that as an inspection of the nursing home facility. But the problem was it didn't give them all the information they needed to make sure that there was actually compliance, and that folks weren't bringing the disease in and weren't spreading it once they're in the facility. And so we really pushed on them to actually do in-person site visits. And they did that, and things got a lot better. So I think those are just 3 examples of where the local knowledge of the situation really has a big impact on how people react to different behavioral modifications that you want, and either comply or don't comply based on the incentives that you create. And so that's why for us, local control is so important, and maintaining that trust is so important, and why we don't think that this should be done with statewide mandates.
Thank you, Colin. Michael, would you like to just jump in and kind of talk about what you're seeing from the regulatory side of things, and how is OSHA going about enforcing some of these things? Can you dive into that a little bit for us?
I'm happy to, and I will say that I actually agree with Mr. Willis that there is a great deal that is best delivered at the local level. Now, from an Oregon OSHA regulatory perspective, and we are a regulatory and safety and health promotion agency. There are other agencies of state government that have more of a service delivery model than we do, but our delivery of services is really framed in the context of the fact that we're also a regulatory agency, and we function in that sense, which does mean that we have to, when we're applying rules and when we're enforcing rules, we have to do it on a statewide basis. We can't have really different sets of rules, at least in our normal framework, for different parts of the state. Now, COVID-19 in the earlier days of the pandemic actually challenged that model a bit, because as we all know, there were varying requirements imposed at the state level, but they did vary depending on the metrics and, at various stages, either the reopening or the risk metrics. And frankly, that put us in a little bit different situation than we're normally accustomed to. What we're looking at right now, they're essentially, we have a baseline rule that we adopted last May. And that rule does include some things like notification, medical removal. It has some basic training requirements. Those things all remain in place. We modified that rule at the end of June to eliminate the requirements related to distancing and facial covering. And so those went away with the June 30th reopening of the state. Since then, the state, the Oregon Health Authority, in consultation with the governor's office and with us, has made the decision that we need to bring back the so-called mask mandates, and ultimately they've come back in three different places. The first is the requirement to use masks in schools. And so as the schools open up, and their focus really is on getting the schools open, as the schools open up, there is an expectation that facial coverings will be in place to protect others in the school. We are one of the enforcement mechanisms for that requirement because schools, of course, are employers. So we have fairly clear jurisdiction because there aren't situations in the schools typically where there are no employees present. The indoor mask mandate obviously had a more sweeping impact on more of the state when the decision was made to bring it back. Oregon Health Authority adopted a temporary rule. We adopted a reference to that rule, basically to put back what we had taken out of our rule at the end of June. And then last week, the Oregon Health Authority's rule was amended to cover outdoor spaces as well. So the basic requirement, and theoretically it applies to all individuals at least, the basic requirement is that if you're in an indoor space that isn't a private residence, and that you're with someone other than individuals from your own household, you need to be wearing a facial covering, and that's without regard to vaccination status. If you're outdoors and you cannot consistently and reliably maintain the 6-foot distance that we've all been talking about for a year and a half, then the same requirement applies. From our perspective, our enforcement of that requirement relates to places where there's employee exposure. So we look at employers. And the significant, in one sense, everything I just described is sort of like, okay, we went back to what the requirements were in April, at least in terms of the statewide requirements. But we are approaching one significant issue differently, at least so far. The Oregon Health Authority rule says that people in control of spaces, primarily employers and businesses, need to make a reasonable effort to ensure that guests into that workspace, customers and clients, wear the masks. And we put out at the same time that the rule took effect an enforcement document that indicates that, at least at present, our perspective will be that if people have the appropriate signage up, if they are requiring their employees and volunteers and contractors, basically the people they have control over, to wear facial coverings, and if they're not actively undercutting the expectation that other visitors, clients and customers wear masks, then we will consider that to be a reasonable effort. So we are not expecting the level of enforcement by businesses that we were expecting from late June of 2020 through the end of June 2021. And so that's really the biggest difference as the mask mandate comes up. Now, there are employers who have basically taken their businesses that have taken the posture that they would put up the required sign and put a sign next to it saying, you don't have to follow that, or if you come in without a mask, we'll just assume you're exempt, and that gets into the issues about actively undercutting the message. And so we have had to deal with that. I think we've talked before about the complaint workload that COVID generated for us, and that it began generating even before the mandates really developed. We actually received in the last year and a half more than 25,000 COVID-19 related complaints. And just by itself, that would be more than 20 years worth of complaint workload. We average about 2,000 a year in normal times. Because of our higher profile, we've received about 5,000 non-COVID complaints in that time. So that's about twice what normal would be. We had reached a point where the complaint volume we were receiving really had trickled off. We actually had 1 week this summer where it dropped into single digits. Not surprisingly, after the renewed mask mandate came into place, we hit 500 the following week. I bring that up partly to note that there are folks out there. I know there's a lot of perspective that, you know, there are just people who want to rat out their neighbors and they're just, you know, Karens or whatever. I guess is the new language for it. My apologies to anybody on the phone call who's named Karen. It's a perfectly wonderful name. But the reality is that there are a lot of people who are very concerned about continued COVID-19 exposures to themselves and to their family and to vulnerable members of their family. There are a lot of employees who are still very concerned. And that's what shows up in the complaint workloads that we get. We have done very few inspections, or we've initiated very few inspections as a result of the renewed mask mandate. As before, our focus has been on making sure that employers know what's required of them through what we call the phone fax process, but what's really a phone email process. And we've engaged with a lot of folks to work through issues. And we've been talking to complainants about the fact that our enforcement expectation isn't the same as it was before. And so some of the issues that they're raising, we're not going to address. I'll just quickly jump in. I see there's a question that says indoor workspaces separated from other employees, such as a private office with a door. If you're separated with a door and a wall, you're in a space by yourself. You're not exposed to other individuals. So the indoor requirement is triggered if you're in a room with somebody who's not a member of your household. Now, sometimes in shared office spaces, that can be a very large room. But if you're in a private workspace with a door that is closed, you can still take off your mask, just as we did last spring. So I don't know whether that gives you a little bit of a frame for where we are. There are other folks on this call who can speak more to why we're here than I can, but I think we all know that the challenges that the Delta variant have brought have stressed the healthcare delivery system, but they've also created risks that we thought we were putting behind us on an individual level and that we still need to tackle. So I guess my plea would be that even though we're taking a little bit less aggressive posture when it comes to enforcement, I hope that folks individually and in their organizations will still continue to take the mask requirements very seriously. And I absolutely hope that you will encourage those over whom you have influence to get the vaccination. I think that there's been a perspective that since the vaccination didn't solve everything at the level that we achieved it, there are some folks who've convinced themselves that the vaccinations have no value. That's simply wrong. And I hope that folks will push on that. See a question about so much discussion on masking, but no discussion on the washing of hands. Why? Well, the reality is that in the transfer of this particular disease, it turns out that washing hands, although that's always a good thing, washing hands and washing surfaces is less critical than we thought it was early in the pandemic. In fact, we have a requirement in our rule for exceptional cleaning in workplaces that we suspended this summer, and that is still suspended. We have not returned to all the requirements in the rule because the surface cleaning really does not appear to be as critical as it appears. Now, I want to be clear, I'm not saying washing hands isn't important and a good idea. The real issue is, do we need to do some exceptional or unusual washing of hands? And it appears that that isn't as critical as we thought early on.
Thank you, Michael. I have a couple of quick questions for you. One, first and foremost, what is the difference between the last kind of enforcement to this enforcement? What has made that a different experience for OSHA? And then the second follow-up question to that is, are you aware of any matrix or anything? What's the matrix that the governor's office is going to be looking at, either additional mandates or reducing the mandates, whether it be complete shutdown, lockdowns, or, hey, you know what, we're going to lift everything and go be free kind of thing?
I guess the easiest thing to say is the most critical indicator are the hospital rates and the hospitalization rates, the bed utilization, and particularly the ICU related COVID treatments. That I know is what Oregon Health Authority and the governor's office is really focusing on as they assess this. Now, vaccines are also an important metric, but ultimately the vaccination success will show up in those hospitalization indicators as well. So I think that it's, without getting into a sophisticated discussion of the metrics, the simplest answer is it's beds in hospitals are probably the single most critical thing. With regard to the difference in our enforcement approach, the reason that we are the reason is really a practical one, and it gets to the point that Mr. Willis said earlier, that there's we rolled back the requirements and then we at the state level reimposed them. We know that as much pushback as we had before, that there's going to be even more pushback now in some circles because of that. And so we are taking the pressure off individual businesses and employers and frontline employees, where we expected them to deny service if necessary. We have changed that expectation, not because it's a good idea to have people wandering around your business who don't have face coverings on, but because we recognize that the enforcement parameters really have changed. And it's not an issue of a change in the medical science. It's an issue of the change in the social science.
Last question for me, and then I'll probably jump to Randy, and then we'll go to Cheryl, because I know Cheryl's got a lot of information that we want to dive into. But with regard to potential new mandates, Michael, are you hearing anything? I keep hearing all about potential vaccine passports and that type of thing coming down the pipeline. You're hearing about it in other communities, things of that nature. Are you hearing any of these rumors? And if so, how is that then enforced? Is that an electronic thing, or is it actually showing a card, et cetera?
I have not heard, I've heard rumors. I have not heard specific plans to develop a vaccine passport. I think the pressure for that is created by the fact that there are a lot of venues and organizations that are requiring attendees to have vaccines. I think the common model is to have either a full vaccination or a recent negative test. There are sports venues that are requiring that. There are a number of entertainment venues in the state and across the country that are requiring that. I do believe that pretty universally, New York's probably the exception, that most folks are simply accepting either the phone medical record, an image of the card, or the card itself. And that really is, there's no standardization there. It's defined by the individual organization. But I think that is the typical model. I tend not to call that vaccine passport. I think if the state launched some sort of vaccine verification, and as I say, I've heard rumors, I haven't heard plans. But if the state were to do that, it probably wouldn't call it a vaccine passport. I think vaccine passport, just as a phrase, has become a loaded term. But we're already seeing vaccine verification. in a lot of different organizations and venues, as well as places of employment, but that obviously doesn't require continuing proof.
Got it. Thank you. As we move forward, again, there's more people that have jumped on the call. We're up to 52. I think when we started, we were around 38. So for those that have jumped in since the call started, would encourage you to put questions in the chat room. And then in addition to that, if you could just address who that question is for, since we have a panel of 4 speakers, that would be great. In addition to that, I did throw probably 4 different links in there as we move forward in the chat for everyone to be able to kind of reference. I would encourage you to cut and paste those and put them into your browser or onto a Word document or something that you could then reference them as we either are done here today or whatever the case may be. That said, Randy, let's jump over to you real quickly. I'm curious from your perspective, what you're seeing from employee relations and how these things are headed from the vaccination mandate, potentially the mask mandate, and then potentially whatever the vaccine, not passport, but whatever particular term that is. I don't remember.
You bet. Thanks, Jeff. And on the mask mandate, it's hard for me to add anything to what Michael has said. I appreciate his insight, and it's really helpful to me. I haven't heard much. My clients initially, when we went back to masking, I think everybody had that dreaded, no, this isn't happening, including me. It's just like, come on, please. What's interesting is that before that announcement, I was at Winco, and probably half, maybe 2/3 of the folks had masks on without any mandate. And so my impression when I'm seeing with clients is that they're not calling me about masking. We've all kind of been there and done that, and we're sort of kind of soldiering through it. But every week of the pandemic has had a different focus, and the focus I've had for the last 2 weeks is on vaccine mandates and how that's impacted healthcare and others. I'm a litigator, and the kind of hallmark of what a litigator tries to do is see both sides of the issue. So I'm not going to weigh in on whether vaccine mandates are a good or bad thing, but I will talk a little bit about the law. Does that make sense, Jeff, to go through that a little bit?
Yeah, in fact, I was hoping that you would jump into that a little bit just to give our group here an idea of what is enforceable, et cetera.
Sure. So just talking about just the private employers generally, the big question is, can employers require vaccination of their employees? And the simple answer is yes, they can. It's at the federal level. It's the EEOC has weighed in on that, and really that is an option for employers to do. There are a couple narrow exceptions. One is disabilities, and one is religious accommodations. And so with disabilities, and you're seeing this in the healthcare mandate of the governor, that all healthcare providers get vaccinated. And that's probably half of my day has been talking to healthcare in the last 2 weeks. Every provider I represent is calling about this. What do we do about the folks that don't want to or can't due to disability? So the OHA has developed a couple forms for healthcare that I think are instructive for private employers who want to adopt, kind of a mandatory vaccination policy. But basically, you can require vaccination unless there's a disability, and the rules talk about physical and mental disability. So physical disability might be like an anaphylactic shock that someone has had, either potentially or actually with their first shot. The rule also provides for mental disabilities. So suppose someone says, if I'm forced to vaccinate, that's going to do all kinds of mental kind of distress to me based on my beliefs or based on whatever the case may be. Basically, if you can get a doctor to sign off on that, I think that's kind of where the inquiry stops for employers. We're not going to kind of second guess doctors on that. So if a doctor says, this person we recommend does not get vaccinated, that's going to usually, the employer ought to stop there. On religious accommodations, it's kind of it's a very loose standard, but essentially you have to have a strong, you have to have a connection between your religious beliefs and your desire not to be vaccinated. the federal law is actually a little broader than the states applying it to healthcare, and that it's kind of, it doesn't have to necessarily mean that you believe in a particular deity. It's more about strong kind of code of how you live your life, that kind of thing. But in any event, if you can tie that, then that's an exception. Now, the documentation that you require or don't require, my practice is I'm not going to get into, okay, well, what does your pastor say? What does the Pope say? Have you ever, how often do you go to church? Any of that kind of stuff. You don't want to, in my opinion, get into that. The regulations talk about it, and they kind of focus on the individual rather than on like the organization of whatever religion you might belong to. So it's really about your personal beliefs and whether others in your, whether others in your church feel the same way. In my mind, is not really relevant. It's more about what that person believes. So if that person can make that connection, and the OHA form has, kind of a connect these two dots. If there's a plausible connection made, I'm advising employers you probably stop there and grant the exception. Now, just because you grant an exception doesn't necessarily mean that you don't take other precautions. And for example, with healthcare, the requirement is you take reasonable steps to ensure a safe workplace. And so suppose that I'm in a job where I'm in very close contact, daily with all kinds of folks, and I'm within a foot or two of them every day, and masking is probably not all that effective. There might be a case there that for saying, look, I understand you have a disability, I understand you have a religious objection, but we just can't accommodate that. We can't provide a safe environment. And so, we can't give you remote work. N95 mask is not good enough, those kinds of things. And then there's other jobs where, you're like our office, we're walking around the halls, we're fairly well distanced, remote work, masking, more frequent testing, those might be reasonable accommodations. So every employer is going to have kind of a case by case kind of distinction there. Jeff, do you want me to talk a little bit? I don't want to just ramble on, but do you want to talk me to talk a little bit about kind of liability issues that kind of come with mandatory vaccination?
Yeah, I think it'd be an interesting thing to hear from your perspective if an employer is mandating that or enforcing the mandate that an employee gets vaccinated and there's downtime or a side effect or something. Is there any kind of liability there for the employer?
Right. Thanks, Jeff. And so a couple things. So let's look at it from the employee standpoint. So let's say you require a vaccination, the employee goes, they have side effects, they have downtime. What's the liability there? And because there's an employment relationship, the liability is essentially covered by the workers' compensation statutes. And so that person would have a workers' compensation claim. And that's kind of where it ends for an employee. So if you mandate the vaccination, just as, if any other workplace kind of illness or injury, it's a work-related illness or injury because you required your employee to do it. From a customer standpoint, I think there's a negligence risk associated with the decision not to mandate vaccinations or not to kind of regulate who's has customer contact. There might be an expectation from your customers that you're providing a safe environment for them. Let's say it's a hairdresser or hair salon, and there's customers with close contact, and you don't really regulate whether there's employees that are vaccinated. And so you might have a customer that gets COVID from the technician. And so the argument might be that because negligence would be the standard, workers' comp doesn't cover any issues you might have with your customers. The argument might be you kind of exposed me to a risk of harm that you knew about and could have taken measures to protect me. And so and the question is, is always, is the risk foreseeable and the kind of the causation. One could say, well, let's give warnings. This person is not vaccinated. This person is vaccinated to your customer. But the problem with that is then you're disclosing medical information about your employee, and unless they give you the okay to do that, you really can't. Medical the information about vaccination status is a medical record that you can't disclose without permission. So it's a real kind of tricky area as to potential negligence claims with your customers.
It's an interesting perspective. I didn't consider that as far as disclosing the medical record. That's an interesting perspective. I had not heard that. Looks like there was a question in the chat.
Yeah, so the question, it looks like the question's along the lines of, let's see. So essentially, I think the gist of the question, if I'm understanding it, is that folks have kind of strong beliefs that aren't religious based about getting vaccinated. I think that's kind of the gist of the question. So let's say that the reason not to vaccinate is based on science or other sorts of research. The law does not protect that. So if it's a political or science or ethical or any of those kinds of reasons not to get vaccinated, there's no exception under the law for that. So for example, with healthcare, if it's not tied to religion, then there's no exception. So the employer can say, look, sorry, that we're going to have to terminate you because we can't, that's not among the enumerated exceptions to the governor's order. Question about terminate for not wearing a mask. Are they able to collect unemployment? Yeah, so if someone's terminated, essentially it's a work rule, right? So if the way unemployment works is you don't get it if you quit, and you don't get it if you're terminated for, sort of just not being a great employee. But if you terminate for misconduct, then you are entitled, or then the employer can fight the claim, right? And so violating a rule the employer has on wearing a mask, violating a rule that the employer has on getting vaccinated would be violation of workplace rule. And my understanding, just from kind of hearing what the employment department is saying, is that most likely, unless there's a religious objection or disability objection, they're not going to grant unemployment to folks who are terminated for failing to wear a mask or failing to comply with the mandatory vaccination policy.
Randy, there's another question here from Column. Can you talk a little bit about disclosure of health information regarding vaccination status? Is this protected information? How can the state require individuals to disclose this to their employers?
Yeah, so I don't know the kind of the legal basis for it. I just know that it is the case that employers can ask for that. Now, the way the ADA works, Americans with Disabilities Act, is you can make medical inquiries as long as they're job related and consistent with business necessity. So you can't ask about anything during the hiring process, anything about a disability. Once you give them an offer, you can ask all kinds of questions, but you got to ask the questions of everyone. And then once they're hired, it's only job related and consistent with business necessity. And I think the argument is that because we're in a pandemic and vaccination status has some bearing on the workplace and on the safety of your fellow employees and customers, it's a job related, consistent with business necessity question. So that's why it can get asked. The other is that the Department of Labor is taking a position that it's not a medical inquiry. So asking whether someone's vaccinated is not a medical inquiry. If you get any deeper than that, it is. So those are kind of the two reasons why, from a legal perspective, it's allowed. But again, once you have that information, keep it confidential, so on a need-to-know basis.
Well, that was the question I was going to ask. Is so if it's not medical information to know the vaccination status of your employee, then why would you be liable if you share that information with a customer?
It is medical information, yeah. And so the employer can ask it. It's not considered, it's a little bit technical under ADA, but it's not considered a medical examination, just asking what their status is. But that is confidential medical information of the employee. And so the treatment of that information is to, I'm sorry, I said DOL, it's actually EOC. The treatment of that information is that you're supposed to be keeping that confidential per the EOC. And so you can't, and this was a big issue when we could not wear masks in the office, right? Because all the employees walking around the office without masks obviously were unvaccinated or were vaccinated because that was allowed. But we still couldn't tell people that, they were kind of self-disclosing by not wearing the mask. It's not the employer's information to tell unless there's actual need to know, kind of within the management level. So let's say you have a customer that says, hey, I'm coming to the meeting, but only if everyone there is vaccinated, for example. You're going to have the permission of folks in the meeting to give that information out to that person.
Got it. Thank you.
Thank you, Randy. I'm sure there's going to be some more questions that pop in. There was a question here about if an employee is terminated for not wearing a mask, are they able to collect unemployment? Did we already cover that? I thought we might have.
Yeah, that's a violation of the work rule. So yeah, they're most likely not going to get unemployment in that situation.
Yeah, thank you. Well, with that, Cheryl, I'm sure that you've got a lot of data and information that you can share with us on what you're seeing at Salem Hospital, and maybe get into some of those numbers and the concerns that you're having. And likewise, I'm sure there's going to be several questions for you as we move forward. So with that, Cheryl, thank you for joining us this morning.
And good morning. It's really interesting because you can't tell what's going on inside our four walls, right? You can't see it. Many members of our community can't see it, even if they have someone in the hospital where normally under outside of the pandemic, lots of people were able to come in and see what was happening. So my report is dire and grim in terms of what's really happening inside the four walls. We have started to invite a few of our commissioners in. Commissioner Gordon from Polk County came in yesterday, or day before yesterday, and visited in our ICU with our lead physicians and staff, frontline staff that are taking care of the patients. Commissioner Willis and Cameron are coming next week. We've had requests from CBS News, National News. We've had reporter requests. We're trying to accommodate a few of those. But I will tell you that only if the individuals are fully vaccinated are we allowing that. The reality is that we are completely full, and we're canceling surgeries, and we're not canceling surgeries that aren't necessary. We're canceling surgeries because we can't accommodate an ICU bed for the patient. As an example, we know they're going to need an ICU bed after a surgery, and we can't do it because we don't have them. So this morning, and this is the reality of what we're dealing with. I do want to make one statement. There is a lot of statements out there about how we in healthcare signed up to do this work and stop whining. We're not whining. We didn't sign up for a pandemic. And we didn't sign up to every single day lose people and not be able to save people. We save people. We lose some. We're losing a lot. And we're losing people that primarily are unvaccinated. So today I have 21 COVID positive patients in my 30-bed ICU, 21. 16 of them are on ventilators, 16. We've never seen anything like this. We didn't see this at the beginning of the pandemic. The Delta variant is a horse of a different color from where we started. And I will tell you quite factually that those 16 are not going to make it. That's the reality of what we're dealing with here. When you see a young mother who's unvaccinated, who's pregnant, and you do a C-section on the young mother to save the baby, and we know the mother's not going to make it. That's the reality of what's happening right now. And I'm not going to sugarcoat this for you. We've been holding patients in the emergency room, upwards of 30 patients that we don't have a bed for. Again, I talked about what's been going on. Part of what's happened is because people delayed care that they really needed during the first year of the pandemic, and it's caught up with them. And so now we're seeing incredibly sick people that don't have COVID, but absolutely have to be hospitalized. So I have 93 COVID patients in beds this morning, 93. A tiny percentage of those are fully vaccinated. The vaccines work is the bottom line here. And, you know, I will tell you, school is starting next week. I have two sons and a daughter-in-law that are teachers in California. They started 3 weeks ago, and it's running rampant through the school systems. And it's running rampant because we have so many kids that are unvaccinated, right? I mean, that's just the reality. This is a bad disease. Most kids do really well with it, but I will tell you, in our community, we've seen an increase in the number of pediatric cases that have to be hospitalized, and we've sent two to specialty hospitals because they are so sick and beyond the capability of what we're able to take care of. So this is real. And again, you can equivocate about the vaccines. Most people that are fully vaccinated that have breakthrough or get COVID do very well. They don't have to be hospitalized. And again, we have a few because of lots of other comorbidities and problems that they have. In the last 2 weeks, we've tested more than 1,000 people that have shown up in our Salem Hospital emergency room and 124 in our West Valley emergency room. We've tested them because they've come in with severe symptoms, and 30% of the people we have tested are positive, 30%. So this is an ugly disease. And the reality is that we're losing this battle. I heard a nurse at Asante on a CBS program last week that said, we're used to winning and we just aren't winning anymore. The commissioners, when they come, will talk directly to the front line staff. It's heartbreaking and they are exhausted. I don't know any other way to describe it to you. They're doing the very best that they can, but there are so many unrealistic expectations. When by the time somebody is in our ICU, they're put on a ventilator, it's kind of over at that point. But the conversations with families that can't come in and see the lack of progress of a loved one are having very difficult time even understanding why we can't do more. Length of stay in the ICU is anywhere from a month to 6 weeks for these individuals. So we're doing our best, but we're not succeeding on that. We've hired just over the past month, 150 additional nursing staff to come into the hospital to help us. We haven't hit the peak yet. The data, we've been following the data pretty closely. As you know, OHSU's Peter Graven has been really monitoring the state from the beginning of the pandemic, and we have really followed the curve that he's put together. The curve is expected to hit the peak next week. So even though we're hovering, I would say in the low 90s in general for the past 2 weeks in our hospital, that doesn't tell the whole story. That means that 17 people went home and 17 or 18 more came in. So this is, and that is the success story of the people that come in, but because they're having breathing difficulty, that's why they're in, they can't breathe. And we're able to get on top of that enough that they can go home and recover at home. But the people that go into the ICU aren't going home. So that's the grim reality. And, you know, when I talk to people, people look at me as an administrator, right? As the CEO of the health system. And I'm talking to you as a nurse today. This is devastating. And I don't know how long we can keep this up, to be honest with you. And the conflict of people that are unvaccinated, and we have a highly vaccinated workforce, but we're not 100%. And want to sugarcoat that with you too. People have very deep beliefs about this. but the majority of the people, our physicians are like 98% in our community are like 98% vaccinated. There are a few. I think there's 11 on the entire medical staff that are not vaccinated. You know, we have more than that in our staff. We have about 25% of our staff that are unvaccinated, and it's through all disciplines. It's not people that are, that is not exclusively people that need more education. So I very firmly feel and will articulate this, that the vaccine mandate was appropriate in healthcare. It's a 1989 law that prevented us from doing this from the beginning. And we have asked repeatedly to have that law amended because we're in a pandemic, and it pointed out a huge flaw in the system, because I need my healthcare workers healthy and able to work. And if they get a breakthrough infection, they can go home, recover, have their 10-day quarantine, and be back at work. I need them. So that law had a provision that a rule could be written in it that would clarify or change the overall premise that you cannot mandate vaccines in healthcare workers. And so the OHA has, under the governor's direction, written a temporary law or temporary rule that allows us to mandate the vaccine. We will have people that leave our organization as a result of this. It will happen. We've given our staff all of the information on the exceptions, the medical exception and the religious exception. So they have that information. We are starting to see people put that in and request those accommodations. We've also seen an increase in people getting the vaccine, not as much as I would like to see, to be honest with that. We are about to get National Guard next week. 160 is what we're looking at to help us. They're not medical people, but we have many, many things that we can help them do, or that they can help us do. And so here we are, right? And I would just say, in our community, the silence about being vaccinated is deafening. I don't know how else to describe it. I sit on the Federal Reserve Board in Portland. You heard that. We had our meeting yesterday. The Federal Reserve Board has now mandated that all of their employees have to be vaccinated. I heard from other segments of business in the Oregon district that we represent, and the language and the difficulty that people are having in deciding whether to mandate or not to mandate. We're seeing more of it. I understand that there's some segments of the business, such as the power business. PGE is on the Federal Reserve Board, and they've had a national discussion, and they have, like in Louisiana's example, they have 15% of the workforce is vaccinated. And if they mandated, they would most likely shut the power down in those areas. So there's some real issues around vaccines, which I totally understand. Masking does have an effect. It's really important, in my opinion, that our community mask, as the governor has asked us to do, because it's a tool that we have. And why would we leave a tool unused? Why would we do that in this circumstance? This thing is deadly. It's killing people right and left. We've now signed a contract for a refrigerated unit for bodies because we don't have any choice. So, you know, I wish I could take this smile and do something with it that would be helpful. But it's the reality of where we are, and people need to get real about this. You really need to consider getting your staff, your teams vaccinated and making that mandatory. The exceptions are there, and they're pretty broad. The religious one is pretty broad, as Randy said. And so people have options here, but that dialogue has to happen.
Cheryl,
So that is my 2 cents worth.
thank you, Cheryl.
Yeah.
I see there's several questions that are popping in here. real quickly, I just wanted to insert a quick question. You had indicated the mask thing. I want to be really upfront and very transparent. I do struggle with the mask mandate in that it's a broad sense of the word. It can be a gator that pulls up. It could be something that doesn't really have an effectiveness. And so from my perspective, I feel like if it was okay, everyone has to wear an N95 as an example, period, no exceptions. That seems more consistent with blocking of the disease. And I also want to be very clear, I absolutely agree that there is a problem here and that there are people dying. I'm not suggesting otherwise. But for someone like me, I see inconsistencies, messaging from politicians, from healthcare people. You admitted that there are some of your staff that will leave. And it would be interesting from your perspective, two things before we get into the questions. And I apologize to everyone else who put their questions in prior to me, but it'd be interesting to me to hear your perspective of how many employees you think that Salem Health is going to lose, not just at the hospital, but across your entire ownership of other facilities, other places across the dual counties. And then a second kind of follow-up question, is there any data that you can share with us that when they say, okay, you have to wear a mask, but it can be a gaiter, it can be an N95, it can be a face shield, the effectiveness of those? So kind of a two-part lengthy question, and I apologize.
No problem. I understand the frustration on the mask. I think we all share that. So I don't, I would not debate with you about the inconsistencies that we've all experienced in terms of wear a mask, don't wear a mask. You can wear a cloth covering over your face. N95s are the best. As you know, during the early stages of the pandemic, we didn't have enough masks. We didn't have enough for our healthcare team. If you've been to the hospital, you know, we require everybody to wear the mask that we provide. When you come in, you're not allowed to wear any of the face coverings that have been allowed under the law on that. I don't have the data in front of me. I think what we've seen is the curve, the flattening of the curve from people wearing whatever form of face covering that they felt was appropriate for them. I wear a regular mask, regular hospital provided mask when I'm out in the public doing things. And so that's my own personal standard on that. But it is real, not only confusing, but I think if you just look overall at the global data, it flattened it. Whatever people were wearing and however they were working in terms of social distancing, closing a business, I'm not advocating for that. I want to be really clear about that. But I think when two people are wearing some covering over their face, it lessens the chance of the transmission. That's the data that's out there. Number of staff that we lose, I really don't know, to be honest. I think this is brand new. People are in the change curve right now. You may have noticed, we had a protest yesterday on the outskirts of our campus from a couple of organizations in the community. I did not see a lot of healthcare scrubs out there. There were a few that joined, about 100 people on Bellevue, Winter and Bellevue, right off, of our campus. So I think we're in the change curve right now. So we will have a better handle on this in the next couple of weeks. The way the regulation or the rule has been written, there is really a short time frame to get fully vaccinated. Fully vaccinated means 2 weeks after your last injection. And so there isn't, this isn't a long timeline either. So by next week, if you're going to get a Pfizer or a Moderna vaccine, you have to have your injection by the 9th of September to be in compliance with the law. So we've given all of those dates to our staff. You can do the Johnson & Johnson and get a 1 shot, and then 2 weeks later be fully vaccinated. But that's the language under the regulation. So we will know more. I'm taking the National Guard specifically because of obviously being worried about not only where we find ourselves right now in terms of staffing and getting some help, but also because of the potential of people leaving the organization. We have good eyes because we are allowed to ask if you've been vaccinated, and we have good eyes on that in our organization. So we know who has not been vaccinated. And so now the strategies that we're employing are, we've got a big town hall on Friday for any staff that want to join that with a panel of trusted physicians. We have physicians that are many of our departments have specialty doctors that they work with all the time. They're talking to individuals that have questions. We're going to open a hotline up for our employees, for our physicians. Again, trusted physicians, physicians that speak in different languages, to be able to answer individual questions. So it's a full court press at this point. So I will know more about who I'm losing by the time we get through the first milestone of vaccinations. So that's a week away.
Great. There's several questions here, and I want to be respectful to those. I've got several others, but I'm going to put mine on the back burner for others because I want to make sure people are getting their questions. So going back, Jonathan Castro Monroy had a question. I think he was the first one. Cheryl, out of the 93 in the hospital, what do we know percentages about the Delta versus the MU variant? Do you have any of that data?
Overall in the state, and our data has been reflecting it, we're about 94% Delta at this point. That's what we're seeing in the state.
94% of the 93 that are in there are Delta. Okay.
Correct.
Looks like Ian had a question. How many deaths are attributed to other diseases that we are not hearing about during the pandemic? A common conspiracy I hear is that no one is dying of the flu, heart disease, obesity, etc. And in other words, the question is that this person is hearing people are dying of heart attack. You're not hearing of people dying of heart attack, influenza, heart disease, obesity, cancer, things of that nature, because it's being attributed to a COVID-19 designation, or I'm going to add to that, or I've forgotten the name of it now, but let's just answer that for now.
Yeah, it is a common misperception. And I think data, certainly in the initial stages of the pandemic, was a little more difficult to track accurately. I don't think that's true anymore. So when you've got 16 people on ventilators because of COVID, they may have cancer. Somebody may have cancer. They didn't die from cancer. They're dying from COVID. So we are very good in our organization at the right attributes. And COVID is the killer at this point. The other part, though, I think is important is that people that have delayed care are also dying. So it's not a COVID diagnosis, but they put off getting their chest pain taken care of. They've ignored it, and they've had a heart attack. They put off getting a cancer diagnosis. And so because of symptoms that they've had, and so now they're in really bad shape when they come in. That's a whole separate, I will call it, consequence of the pandemic. It's not because they died of COVID, but the pandemic itself has really led to a lot of people being too frightened to come into the healthcare system, even though normally, under normal circumstances, they would have. And so we've seen that pent up demand for healthcare and death as a result of that.
Okay. Question from Brent at 8 o'clock. We hear a lot of complacency comments like only the old people are dying. Do you have any data that shows the age bracket of COVID patients?
Yeah, our average age is 52 now.
And what was the first wave? Was it older?
It was elderly. It was elderly, and it was, the over 65, 70, 80, 90-year-olds, because they were, there was no vaccine, there was no protection. The masking was about it. And most of them died in the residential care facilities in our community, and that's true. That's true nationally and in our state also. That has, since the vaccines and the vaccination of residents, and the over 65 population is very well vaccinated in our community. That's really dropped. So, we lost the 35-year-old this week. Guys, this is not a joke. This thing doesn't care if you're old or you're young. It cares how your body reacts to it and how your lungs shut down. That's what it cares about, not your age, not anymore.
And is that Delta specific as far as not your age anymore?
Yes,
Or is that just
absolutely.
a general rule?
Absolutely.
Gotcha.
The Delta variant is viruses mutate, and they mutate in people where the person is a host. And in the case in our community, it is unvaccinated people by and large. There are some, obviously, that have breakthrough. And I will say that my son, right now, who's a teacher, had a breakthrough. He's fully vaccinated, but he's home. He hasn't had to go to the hospital. He's done fine. It's like he has a head cold at this point.
Got it.
Yeah, so you need to get vaccinated. And you need to be verbal about vaccinations work. And yes, there's breakthrough, and we have the occasional person that has breakthrough that comes that's sick enough to come into the hospital. But by and large, you're about 25 times more likely to end up in the hospital if you're unvaccinated compared to the vaccinated rate.
Well, I think that's good information to have. Thank you. 25%. I think that's an interesting data. Richard Pine asked, would you please talk about the impact on your staff when they hear businesses, politicians, individuals fighting against mask mandate? Is there more businesses could do to help you and your staff?
Yeah, I mean, again, I'm not going to sugarcoat that we have a percentage of our staff that are unvaccinated. And we, generally speaking, don't have a problem with the mask mandate. People are pretty compliant in our organization in terms of wearing masks. And I would say that our unvaccinated staff are very compliant. We've not really seen any kind of an issue around that. And so I think you'll hear the dialogue everywhere about whether it's necessary, whether it's not necessary, what's the data. I think Michael Wood could probably do a better job than I can in terms of the data around masking. So the debate is there. There's no doubt about it. But the reality is it's a tool, and we know it's a tool that had some effect. It didn't stop the virus. And everybody who gets the virus now is a host that the virus then decides, wow, I can live a little longer if I mutate just a little bit over here. And that's what it's an organism. It's trying to survive. And as long as it's got a host, it's going to survive and it's going to mutate.
Along those lines, Cheryl, two questions, I guess. Do you have any data that you can share about how many of your employees, in essence, do not have the vaccination? I mean, do you have
1,200. I have 1,200 employees out of 6,000 that are unvaccinated.
And do you believe that those full 1,200 would bail out of the system? I mean, I'm hopeful that that's not the case, but that's an interesting.
This is a tough topic, right? And you all are experiencing it too. And there are people on this call that are unvaccinated. So I understand that part of it. And I honestly do not believe 1,200 people are going to leave. And we're trying to figure out, we have about a third of our workforce right now that's working from home. That's exempted from this rule if they work 100% from home. So we're trying to adjust and accommodate and figure that part of it out, because sometimes people still have to come to the hospital to complete work. So we're trying to figure that out. And then, so they're included in that number, but they'll be exempted. So it does start to get the number down somewhat, but we have clinical staff that are unvaccinated. And those are the ones, it's not that I'm not worried about everybody, but those are the ones that worry me the most right now, because our resource for replacing those people is, it's pretty tight. That's why we hired 150 new nurses to come in. And we'll be fighting you're required to be vaccinated, that group, as they come in. We've given them that information. Again, we know because we are absolutely legally allowed to ask those questions. We know who, we know where our biggest vulnerabilities are in terms of workforce shortage. What we'll be doing over the next couple of weeks is shoring up all of our plans for how we'll fill, with some assumption that some of those people will leave, and we'll actually approach it as if all of them were going to leave. And how will we make sure that we have good plans in place? Because we're here to take care of the community. That's what we signed up for, and we're doing our darndest here. And so my team and I have good eyes on this, and we are problem solving. How would we fill blah if if a group of people decided to leave? We're fortunate in that we're not just a hospital, we are also an outpatient. We have a lot of outpatient departments. And so again, it may be moving staff from outpatient and closing outpatient and moving them into the hospital. So we believe we'll be able to manage this.
So for everyone on the call who has a business, and the majority of us are business owners, small business, or in some regard, large business, regardless, we all know what it costs to take care of staffing turnover, one of the top expenses in any business. To put it into perspective, using Cheryl's numbers, approximately 20% of their staff, they're preparing for potentially 20% of their staff to leave because they're unvaccinated. So that's I could see where that's a big issue.
Yeah.
Randy, it looks like there's a question. I'm going to assume it's for you from Treva. How can we let go of those that have strong beliefs when the workforce shortage is already causing us closures?
Yeah, that's certainly a practical problem rather than a legal problem, and I wish I did have an answer for that. I will say and I don't want to undercut Cheryl's message, because I'm kind of having this is just it's a rough thing to hear. I have clients with all kinds of different perspectives, and so I have to advise clients based on what their goals and needs are. I have some clients who are very worried about turnover, and they are, they're going to be applying a much more lenient standard to religious exceptions and disability exceptions. I have other clients who feel very strongly about that their folks need to get vaccinated, and they're going to apply a stricter standard to these things. And so, as a practical matter, you need to run your business, and you got to do what you feel is morally and ethically and operationally correct within the bounds of the law. And so I help employers on both sides of that. But it is a challenging issue to lose folks, especially right now when it's hard to find folks, even when you tempt them with massive starting bonuses and things like that, like many of my clients are doing. And every day with my client, when I say, hey, by the way, how's your business doing? They all say, I need people. I don't have enough people to do the work. Every single client says that. So it is a problem.
Thank you, Randy. Cheryl, there's a question from Brandon Blair. Do you see that the breakthrough cases in our community occur with more with one specific vaccine over the other?
No, actually, I haven't really looked at data, but I think generally speaking, when most of our healthcare workers got Pfizer, West Valley, they got Moderna. I haven't seen any differences in the breakthrough, so that's kind of the small sample that I would look at. It doesn't appear to be very much difference in those two vaccines. And I don't really know, we haven't done a lot of Johnson & Johnson in our communities. I don't really have any kind of feel for that one.
Gotcha. Let's see. TJ asked a question here. What side effects of the vaccines are we seeing? I got the first Pfizer shot, and 10 hours later, he had the stroke, of course, that we all know about and struggle with. And he says, my doctor tied back to the shot and high blood pressure. Are you seeing any of that type of data, Cheryl, that you can share?
Yeah, well, I think again, nationally, there will be some people that will have more severe side effects. TJ, very sorry for what happened to you. But the overwhelmingly, it's not the case. And so it's a very, I think the fact that our doctors are like 98% in this community vaccinated should give you some comfort in terms of the safeness. But yeah, there's no medication that's ever been created that has some side effects haven't occurred. I mean, that's just a reality of it. So this isn't any different than that. And so the severity, when we gave over 275,000 injections in our mass vaccination work that we did, and also with vaccinating the healthcare workers, and we had one anaphylaxis in that whole 275,000 where somebody had an immediate reaction to anaphylaxis. That's why we made people say 15 minutes or 30 minutes, depending on their health condition. So we have not seen very much of side effects.
Cheryl, when we're looking at some of the data, I sent out several links when we first got on the call that hopefully people had an opportunity to at least cut and paste into their browser and look over. I noticed that there's a comment in there about COVID and presumptive. Can you explain what presumptive means to a dork like me? Thanks.
Well, it took a little bit for me to wrap my hand around it too. It just means you have the symptoms that are COVID-like symptoms and we're waiting for the test, but we're treating you as if you have COVID. So once the test comes back, then we know if you have it or not at that point. So there are still other respiratory things that people get that look like COVID that aren't. And I think our conversion rate on that is about 30%. I think it's mirroring what we're seeing in the emergency room. It used to be a lot lower again with the first, with the COVID-19 when it first started hitting. It was like less than 10%. We're seeing about 30% now.
So is there any data that shows when someone is presumptive, in other words, they're being counted as COVID, even though it's presumptive, then does that number come back off when the quote unquote 30% says that they're not COVID related?
Yeah, I don't know how the OHA tracks that. I think that the number kind of sticks there, but I don't know how they figure that into the calculation. I don't know that information.
Okay.
I look at our data in our organization, and the 93 patients are COVID positive. They are not the presumptive. We have presumptive also, but we separate out the data. So we know how many people are in our organization that are presumed and we are awaiting testing, but they're not counted as a COVID positive patient. So 93 is what we have today.
Gotcha. That's really interesting. I know we're getting to the end here. We only have a couple of minutes. We're at 8:28 and hate keeping people here longer than necessary or longer than scheduled, certainly. So with that, I think I want to kind of just pause it right there unless there's any additional questions. It looks like Michael would just put something in regarding the effectiveness of masks. Everyone can read that real quick. I just want to say thank you to the four panelists that are here. I think to Cheryl's point, this is a very sticky wicket, and I think that there are people that are deeply convicted on both sides of this thing. And I think that there's a lot of information that's inconsistent and perhaps misinformation on all kinds of sides. And it becomes very difficult. And I'm speaking for myself, not for anyone else. It's very difficult to decipher what is right and what is wrong. And I understand what Cheryl's saying, and I agree with everything that Cheryl said. For the most part, this is a really difficult situation, and I don't envy any one of the four of you being in the situation that you're in, especially Cheryl, and frankly, Michael, for having to enforce some of these things and difficult times. That's all I can say. That said, thank you very much for being here. Zachary, do you want to have any closing statements or?
Just wanted to say thank you again to all of our speakers and all of our guests for being on here. We got up to 62 participants at one point. So clearly this is something that our business community is really concerned about. So thank you for everyone that made the time to be here, and especially to our speakers. I know all of your time is incredibly valuable, and our organization is deeply thankful for that. We will have this public policy meeting up on our YouTube channel and website within the next 48 hours. So thank you again, everybody, and hope you guys all have a fantastic rest of your day.
Thank you, everyone.